Ma'am, please start.
Yeah. Hello. Good evening, everybody. Myself, Dr. Veena Venkatesh, working at Ajanta Pharma Limited as General Manager and taking care of the Medical Services Department. On the behalf of Ajanta, I welcome each for today's scientific session. Today, the session is going to be calcium channel blocker and its role in CVD. Today, we have with us a very eminent cardiologist, Professor Dr. Soumitra Ray, and I have a privilege of introducing to the audience. Sir, as by the qualification goes, he is MD in General Medicine with many FCSI, FICP, FESC and FACC. He is a consultant interventional cardiologist, director of invasive cardiology, AMRI Hospital, Kolkata. He is a professor, Vivekananda Institute of Medical Sciences. He is ex-vice president of Central CSI. He pursued UK after completing his MD from Kolkata Medical College, completed training as cardiologist from the Royal London Hospitals. And he is a very bright student, stood first in all the university examination. He has published several papers, reviewed articles, chapters in cardiology books in India and abroad. He represented CSI in international conferences. With this brief introduction, I'll just hand over the session to Dr. Soumitra Ray. He would take over the proceedings later on. Sir, over to you, please.
Thank you, Dr. Veena, for your very kind introduction. Thank you and welcome to all the delegates who have logged in to this evening symposium. Now, you are having symposium and webinars almost daily, more than one, I understand. And there are two basic themes of today's symposium. One is COVID related, one is not COVID related. Today's symposium is in the second group. So we are not discussing COVID or related issues today. We might have one or two questions at the end regarding the relevance of COVID with today's discussion. But basically our discussion focuses on, Pankaj, next please. Okay, our talk focuses on the role of calcium channel blocker in cardiovascular disease. So there is a little clarification needed. Usually we talk about calcium channel blocker in hypertension and comorbidities, but here we are focusing on the comorbidities, that is the associated cardiovascular disease with hypertension, how the calcium channel blockers fit in. Also, I may say at the beginning that by calcium channel blockers, we mean two broad categories of calcium channel blocker. One is the DHP group, which is represented by nifedipine and amlodipine. And one is non-DHP group, which is represented, actually are represented by diltiazem and verapamil. We will restrict our discussion to the former group, that is the DHP group, because we want to the control of hypertension and the related comorbidities. You know that diltiazem and verapamil are not so good in controlling hypertension. They are mostly primarily cardiac drugs. So that is beyond our discussion today. So with that introduction, let's have the background ready. We know that hypertension worldwide is a very menacing condition. About 30% adult population are having hypertension in India, 35% in urban India, and around 25% in rural India. Even more scary data came about 3 years ago when it was shown that even in school-going children between the age of around 12 to 15, around 20% of them are already hypertensive, even in their teens. So that is a very scary data. And of course, that is a very focused research. It was done by Dr. Anita Saxena's group from New Delhi. If it is widespread, we really do not know what is the real scenario in the childhood population of India. And you know that everyone can take 5 concrete steps to help prevent high blood pressure, which includes diet, physical activity, avoiding tobacco and excess of alcohol, and managing stress in healthy ways. These are very, very important, and if properly followed, then many hypertensions will never require any pharmacotherapy in their lifetime. But still some will require pharmacotherapy. And of course, being human beings, we cannot stick to this strict lifestyle all the time. So perhaps pharmacotherapy is the easier solution to control the blood pressure. Next, please. Next, yeah. Now, as we have already known by WHO famous slide, which was published in 2003, that hypertension is a silent killer. It does not give you symptom or sign in majority of patients, and they do not understand that they are hypertensive, or even when they are on medicine, whether their blood pressure is controlled or not. Many factors which indicate the patient can be hypertensive are due to socio-economic conditions rather than patient's health, which includes globalization, urbanization, aging, income, education, and housing. As you know, that blood pressure has got a tendency to increase with age. So as the population ages and the percentage of elderly people in a particular society is increasing, then naturally the percentage of hypertensive patients will increase in that population or in that society. With their socioeconomic determinant, we add ourselves the behavioral risk factors, as I mentioned, with diet, tobacco, alcohol, and physical inactivity. And they breed not only hypertension, some other conditions grow in the same soil, including obesity, diabetes, and dyslipidemia, as we call them metabolic syndrome. And this metabolic syndrome not only cause ischemic heart disease, they cause stroke, they cause heart failure, as well as renal dysfunction. So hypertension we cannot really discuss in isolation. We have to see the background, we have to see the comorbidities, and we have to see all the target organ damage produced by hypertension. Next, please. Now, if we go by your Indian guideline first, which was published just last year by Indian Society of Hypertension, there is an Indian guideline for hypertension. It is the stage 3 hypertension. It was being produced for some time now. Now here the calcium, you know that all the major groups have been depicted, including diuretics, calcium channel blockers, ACE inhibitor, and ARB. As you know, these are the first line drugs as advocated by European Society of Cardiology as well as ACC. Now where we place the CCB in Indian scenario? There is definite indication. First is metabolic syndrome, which is rather unusual, which is not usually mentioned in the ESC or ACC guidelines. Angina, I'll come to that. Elderly people, isolated systolic hypertension, as well as diabetes. They are more important in peripheral vascular disease and CVA. We'll also look into that. And they are contraindicated in heart block, but here I must mention that this is for verapamil diltiazem, which are contraindicated in heart block. The DHP calcium channel blockers are not contraindicated in heart block. Next, please. Now, just to recapitulate, you all know that though the definition of hypertension varies across the Atlantic, by Europe it is 140/90 is the threshold, and in America it is 130/80 threshold. But ultimately the BP goal is the same, that is 130/80. Here we also Indians agree that once the person is diagnosed to be hypertensive by his baseline BP above 140/90, we start treatment. Of course, after the lifestyle management, we start pharmacotherapy. And once we start pharmacotherapy, we should target the BP to go down below 130/80. Now there is a little difference between America and Europe. In America, they said, if the blood pressure goes down with your treatment, let it fall down as much as possible unless the patient is symptomatic, like postural hypotension. So there is no lower limit they have set in. Whereas Europeans have set in a lower limit as well, which is a narrow range. They said the ideal blood pressure should be 120 to 130 and 70 to 80. If it goes below 120, systolic or goes below 70 diastolic, then there is need to reduce the pharmacotherapy to keep it slightly up in the target range. So there is a fundamental difference which we Indians are following. Next, please. Now, if we go by the European guideline, I'm not going into the general slide, but we focus on the hypertension in coronary artery disease. And here you will see in the initial therapy, calcium channel blocker features very much. I'll show in the next slide, which is published only last year. Next, please. Which is not a hypertension guideline. Acha, no. Right. Yes. Which is not the hypertension guideline, but this is actually a guideline published by European Society of Cardiology last year for treatment of chronic coronary syndrome, which we used to know as chronic stable angina. Here, if you see, very interestingly, the left top corner you see, standard therapy is beta blocker or calcium channel blocker. And if you go down by the letter A, you see the A, if you go to the footnote of A, combination of a beta blocker with a DHP calcium blocker should be considered as first step. So here you see that beta blocker and DHP calcium channel blocker, they are the drug combination of choice in unqualified angina. Now, if the heart rate is high, you prefer diltiazem or verapamil. But if the heart rate is low, below 50, as for example, then even beta blocker is not there in the box. Even verapamil, diltiazem is not there in the box. What remains in the box is dihydropyridine calcium channel blocker. This is the only drug of choice in stable angina when the initial heart rate is low. And it is in combination the drug of choice in unqualified hypertension. So you see, and if you see, go down the box, you will see in the second and third step, calcium channel blockers are everywhere. Really, they are everywhere. Next, please. Next, please. Now, if we see and go back, please. Go back. Yes, stay there. If we see the network meta-analysis of first-line treatments that we have discussed in randomized controlled clinical trials in hypertension, we get some very interesting findings. If you see, the diuretic is taken as a standard and other treatments have been compared with diuretic. Of course, compared to placebo, if you see the panel A, compared to placebo, diuretics reduce all parameters. That is the overall outcome, coronary heart disease, heart failure, stroke, cardiovascular event, cardiovascular mortality, as well as total mortality. Now, if you compare now diuretic with some active treatment like beta blockers, they are almost on the neutral line, still favoring diuretic. If you compare them in panel C with ACE inhibitor, again, most of them are on the neutral line, still a little favoring diuretic. Now you come to panel D, where comes the calcium channel blocker. And if you see again, they are almost equal in all parameters, excepting heart failure, where of course diuretic will have an edge over all other groups. So basically you can see all the groups are more or less comparable. Diuretic has got slight edge over other groups. Calcium channel blocker is almost same as diuretic. Next, please. Now, if you see the clinical significance of calcium channel blocker, now we zoom down our discussion to calcium channel blocker, and as specifically I said, to dihydropyridine calcium channel blocker. You know, there are multiple types of calcium channels in our cell. The fundamental three are L-type, N-type, and T-type. There are other also P, Q, and R. We do not discuss those because those are not clinically relevant. If you see what these channels do, L-type, they reduce heart contractility. Sympathetic nervous system is stimulated, so pulse rate tends to increase. if we block this L-type channel. And in the kidney, these L blockers increase glomerular pressure. So these L-type blockers, which is prototyped by nifedipine, they reduce contractility, increase pulse rate, and increase glomerular pressure. N-type blocker, which is prototyped by cilnidipine, I'll tell you later why, they reduce heart rate and contractility to some extent. Pulse rate they reduce, intraglomerular pressure they reduce. The T-type, it is also there in the ephonidipine group. They have all this character. With that, they have also got aldosterone secretion diminution. So these are some intermolecular variation within the group of DHP calcium channel blocker. Next, please. Next, please. Please make the slides properly. Now, as we can see, yeah, that's better. Please take care of the slides. So what we see here with cilnidipine, that L-type, please do not change. Go back. Go back. Please stay here. So once we block the L-type channels, you know the L-type block causes vasoconstriction. So when we block the L-type channel, there is vasodilatation. That is very important, the fundamental mode of action, anti-hypertensive action of this group of calcium channel blockers. What does the N-type do? Look very carefully. What the N-type blockage does, they reduce the sympathetic drive. Release of adrenaline and noradrenaline are reduced from the nerve ends. So naturally, you will expect further vasodilatation. You will expect heart rate to go down. And I will explain later, you will expect intraglomerular pressure to fall. We'll come to that later on. Next, please. And if we see all the calcium channel blockers that has been depicted in the box, amlodipine, cilnidipine, nimodipine, nisolidipine, and nicardipine, you will see that cilnidipine has got the highest N-type specificity compared to L, which is almost 50 times more compared to amlodipine. So cilnidipine is 50 times more adrenergic blocker compared to amlodipine. So almost it works a bit like a beta blocker. Next, please. Now, if we further analyze the effect of cilnidipine and amlodipine in hypertensive patient who had a cerebrovascular accident. This is an interesting trial. You look here, risk of cerebral stroke is much more after a previous stroke. You know, the second stroke is common. Autonomic nervous system dysfunction occurs in a majority of patients after a CVA. This we have to keep in mind, that after a brain stroke, there is high chance of developing autonomic nervous system dysfunction. Now, antihypertensives like cilnidipine, which suppress the sympathetic nerve activation in hypertensive with chronic stage CVA in comparison with amlodipine. Let's see whether they make any useful difference. In this trial, amlodipine was given 5 to 7.5, or cilnidipine was given 5 to 10 milligram to 78 hypertensive subjects who all had previous cerebral infarct. And after 3 months, we checked their pulse, their blood pressure, and their 24 hours blood pressure. Let's see what happened. Next, please. Here you will see that in 24 hours blood pressure, if you see the left side in the systolic blood pressure, with the patient, you see CI means cilnidipine, CIC means cilnidipine with CVA patient. AM means amlodipine treatment, AMC means amlodipine treatment on severe patient. You will see that blood pressure lowering is hampered when the patient had cardiovascular accident before with amlodipine. The blood pressure is significantly higher in severe patient on amlodipine. But with cilnidipine, the reduction of pressure is same whether the patient had previous severe or not. So previous severe does not affect the efficacy of cilnidipine, but it hampers or dampens the efficacy of amlodipine. You see the awake panel on the right side, again the same thing happened. Irrespective of the previous severe status, cilnidipine treated patients had good control of blood pressure, but in amlodipine treated patients, if there was no CVA, they were okay. But if there was previous CVA, amlodipine could not control the blood pressure or systolic pressure so nicely, though the diastolic pressure difference was not significant. Next, please. Next, please. Yes, stay there. And if you see the anti-hypertensive effect of cilnidipine and amlodipine in hypertensive patient with CVA, as I said, in patient with the recent CVA, a calcium antagonist with no sympathetic nerve suppression, that is amlodipine, had weaker blood pressure lowering effect. Significantly increased pulse rate variability shown in the CVD subject administered cilnidipine suggests that cilnidipine enhanced the parasympathetic function in hypertensive patient. That means the balance between sympathetic and parasympathetic is not changed with amlodipine, but with cilnidipine, parasympathetic is upregulated and sympathetic is downregulated, so that the wake up systolic blood pressure is better controlled as well as pulse rate is better controlled with cilnidipine as compared to amlodipine. Next slide, please. Now there is another interesting aspect of cardiovascular disease and cilnidipine. It is called CA-ATTEND study, was in Japan. There are two studies. In study 1, effect of cilnidipine was assessed with carotid atherosclerosis. We know that carotid intima media thickness is part of target organ damage of hypertension, as well as it indicates atherosclerosis. Still, it remains unclear whether the antihypertensive agents affect the interadventitial diameter. Carotid intima media thickness is diminished by several antihypertensive, including ARBs and calcium blockers. But interadventitial diameter, IAD, there is no proper study. So this study in Japan aimed to examine whether cilnidipine reduced both the carotid IMT as well as IAD in post-stroke hypertensive patient, and that becomes more relevant in previous severe patient because there is already some higher chance of getting carotid disease. The common carotid IMT and IAD were measured at the beginning of the study and after 1 year. What we found, the changes in the mean maximum INT and IAD between baseline and the 1 year follow-up were evaluated and compared between two groups. One group where the baseline IMT was more, that is more than 1.1 millimeter. And the second group where baseline IMT was normal, that is less than 1.1. There was more than 600 patients, all had stroke before. Age was around 70 years, half of them were male, and they are included. Next slide, please. Without going into the nitty-gritty of the trials, which I removed for your convenience, I come to the conclusion directly. It was shown that common carotid artery of 326 post-stroke hypertensive subjects undergoing cilnidipine treatment compared to placebo, the reduction in the maximum IMT at 1 year was observed in the baseline thick group, but it was not affected when the baseline was normal. So that is good. That's what we want. The reduction in IAD was observed in both groups. Perhaps this is the first study where interadventitial diameter was measured and was shown to be reduced convincingly by cilnidipine. The treatment with cilnidipine promoted the regression of carotid atherosclerosis in post-stroke hypertensive patients. So this is a newer aspect of any calcium channel blocker treatment to show that they have got some effect on atherosclerotic process in the body, which was never shown before. Next, please. The second part of the study was a bigger study, that CA Attend Study 2, which had 2,667 patients with 60% male, and average age was again same, the 70. It was a prospective randomized control trial treated with cilnidipine with regard to blood pressure control and adverse reaction. They are again minded all post-stroke patients. Cilnidipine treatment caused a decrease in both clinic as well as home blood pressure 2 months after starting the treatment. Reduced blood pressure was maintained until the end of 1 year. The proportion of patients in whose clinic blood pressure was within range, that is totally controlled, it was increased from 20% to 60%. So a threefold jump in control of blood pressure, which is tremendous by any standard, with no difference in effectiveness among the various subtypes of stroke, whether it is intracranial hemorrhage, whether it is subarachnoid hemorrhage, whether it was ischemic stroke. Everybody showed the same jump of blood pressure control. In total, there was some adverse event around 346 with an overall incidence about 9%. And there was only one incidence of fall and hip fracture. Next, please. Here you will see that systolic blood pressure came down within 140 very quickly after starting the treatment within a month or within 2 months. If you scan them between morning blood pressure and evening blood pressure, you will see both of them have come down below 140 within first 2 months. Same also the blood pressure, heart rate. If you see the bottom panel, that is the pulse rate, they were also from about 2 to 4 decrease, particularly in the daytime decrease, but because as you know, the daytime heart rate is more related to adrenergic surge, sympathetic stimulation because of patients is awake. And here it is from 74 to 71. So quite an useful reduction of mean pulse rate, which was not so much in night time, because nighttime heart rate is not so much dependent on adrenergic surge. Next, please. And as I mentioned, irrespective of the type of stroke, they showed the benefit. Whether it was a large artery, like a, say, carotid artery blockage producing stroke, or a small vessel, say, MCA territory stroke. Whether there was a stroke with cerebral hemorrhage or there was subarachnoid hemorrhage. In all subtypes of stroke, it was shown that both the daytime and nighttime blood pressure were very well controlled with cilnidipine, with the effect starting from month 1, getting the maximum benefit in month 2, and which is sustained at least up to month 12. Next, please. So if we see the conclusion of this study, cilnidipine treatment was effective against uncontrolled blood pressure and well tolerated in Japanese post-stroke hypertensive patient in a real-world setting. Results assist in the generalization of the finding from RCTs in the routine clinical practice of Japanese stroke patient. So in Japan, after a stroke, next please. Now, effect of cilnidipine on changes in heart rate and QT interval. As we said that it was a very specific trial which took only the hemodialysis patients. We know that hemodialysis patients with hypertension have got very poor prognosis and their sympathetic nerve activity is pretty high. So there is a very much yo-yoing of blood pressure and pulse rate before hemodialysis, during dialysis and post-dialysis period, and sometimes it becomes very difficult to control the blood pressure and pulse rate in hemodialysis patients. So here it was thought to see whether cilnidipine will do some good because they are anti-adrenergic. So it was tried. They were given amlodipine for first 1 month, then next, please. So what was shown, I'll just go to the conclusion that increased sympathetic nerve activity leads to lethal arrhythmia in hemodialysis patient, that we know. Cilnidipine have beneficial effect in reducing this cardiovascular event because they reduce the adrenergic surge. And if you see the QT prolongation, you see the right panel. A is for amlodipine, C is for cilnidipine. Before and after the hemodialysis, there is a sympathetic surge and QT prolongation occurs with amlodipine treatment. But with cilnidipine, the QT is not further prolonged after the dialysis. So as you know, with QTC prolongation, there is chance of torsade de pointes and sudden cardiac death. So with amlodipine treatment, the chance may increase, whereas with cilnidipine, the chance is not further increased. Next, please. There is some other aspect of cardioprotection. It was a study of 32 patients with hypertension. Some were given cilnidipine, some were given nifedipine. And what they wanted to study is the ventricular parameters by echocardiogram. End diastolic volume, end systolic volume, ejection fraction, and some PFR. It was found, I'll just make the gist for you to make life simple. After 6 months, after treatment with cilnidipine, LV diastolic functions improved. If you see the end diastolic volume, end systolic volume compared to nifedipine, there was some deterioration with nifedipine, but with cilnidipine, there is some objective improvement. Though not all of them reached significant p-value, but there is a tendency for all the parameters to improve, including the ejection fraction. Next, please. There is another interesting aspect with cilnidipine and cardiovascular conditions. As you can also understand that because of adrenergic surge, as I mentioned, there is chance of more heart attack, there is chance of more sudden cardiac death. Also, there is chance of more atrial fibrillation. You know that it is sometimes adrenergically driven. So here we have seen that with cilnidipine, as it blocks the noradrenaline release in the nerve ends onto the right atrium and left atrium, chance of new onset atrial fibrillation in hypertensive patients treated on cilnidipine are substantially low compared to treatment with other modalities. We already know that angiotensin receptor blocker or ARB is a very good group of drug, class of drug, which prevents the first onset of atrial fibrillation. We can have another shot in the arm in form of cilnidipine, not just any other calcium channel blocker, but specifically cilnidipine, because sometimes it may so happen that your blood pressure patient is not suitable for ARB because of renal function, because of potassium, because of some other reasons, allergy, etc. So here, your drug of choice will be cilnidipine, which perhaps will reduce the first onset of atrial fibrillation in a hypertensive patient with a hypertensive heart who are very prone to develop atrial fibrillation. You can gauge them when there is hypertension with LVH, when there is hypertension with left atrial enlargement, when there is hypertension with LV diastolic dysfunction. These are the three groups of patients who tend to develop atrial fibrillation as a complication of hypertension. So this group of patients are particularly suitable to be treated with cilnidipine. Next, please. And lastly, if we see the cilnidipine versus amlodipine significantly decrease the ambulatory blood pressure level without causing a heart rate increase. As I said, again, the anti-adrenergic effect comes into effect here also. The daytime pulse rate is not usually increased with cilnidipine. There is a little tendency. There's a little tendency. That's why if you remember the ESC guideline chart as I showed in the beginning, they said if heart rate is below 50, you give this amlodipine group of drug. If it is above 70 or it is tachycardia, then you consider verapamil or diltiazem, because they know that amlodipine has got a little tendency to increase the heart rate. But Europeans and Americans do not have cilnidipine. So they do not really know the properties of cilnidipine, and they don't have any trial with cilnidipine. Otherwise, perhaps they would have mentioned that cilnidipine can be given instead of verapamil or diltiazem in this group, because it is really very neutral as far as heart rate is concerned. Next, please. And last, but maybe the penultimate aspect is that pedal edema. We all know in our clinical experience that a substantial number of patients develop pedal edema with amlodipine, maybe around 10–15%, maybe up to 30% in my clinical experience, which may not be there with cilnidipine. Next slide, please. Actually, this it is an Indian study published from Manipal, from Kasturba Medical College at Manipal. So it is a very credible study, but the results are too good. They showed that administration of cilnidipine for 1 month, complete clinical resolution of ankle edema in all 27 patients. As I said, it is sometimes very difficult to believe, but in my clinical experience, at least the majority of patients have got considerable improvement in pedal edema when we shift them from amlodipine to cilnidipine. Not all of them have the effect, and not all of them have got complete resolution, but most of them have got a major resolution of pedal edema. That much we can say. But some people are really resistant and they develop pedal edema with any kind of calcium channel blocker, including diltiazem and verapamil. They are very, very sensitive to any calcium channel blocker. So those patients are exceptional. Next, please. And lastly, the cilnidipine with renal disease. Here there is no doubt that cilnidipine is very good to reduce the intraglomerular pressure, to reduce albuminuria, and in turn to reduce deterioration of renal function. Cilnidipine dilates efferent arterioles, leading to lowering of glomerular pressure, whereas amlodipine dilates only the afferent arteriole. So there is more blood rushing into the glomerulus and the outlets are narrow, so the intraglomerular pressure increases, there is albumin leakage. But if the outlets are as dilated as the inlets, then there is no chance of building up of intraglomerular pressure. Renin-angiotensin inhibitors also dilate efferent arterioles. That is the mechanism of renoprotection of ACE inhibitor and ARB, but that is a different mechanism. So combination of cilnidipine with a renin-angiotensin blocker can result in therapeutic synergy on efferent arteriolar dilatation or proteinuria. So that is an ideal combination in renal patients. Next, please. So finally, before going to final, I will also say there are also some anecdotal evidence that cilnidipine, specifically in the group of DHP calcium blocker, has got beneficial effect on the lipid profile of human beings. That LDL, it tends to decrease, TG tends to decrease. So these are some added benefit of cilnidipine. And also there is some safety trial with heart failure patients, though generally in severe systolic heart failure with reduced ejection fraction, patient in class 3 or 4 NYHA, we do not prefer DHP calcium channel blocker as a group. But in diastolic heart failure, as I mentioned, this is the drug of choice. So we have to differentiate between the type of heart failure in a patient. So to sum up, friends, benefits of cilnidipine are basically renoprotective and cardioprotective. In kidney, they reduce proteinuria by 50%, prevents increase in glomerular pressure. They indirectly also helps the RAS blockade and prevent angiotensin II induced damage to podocyte by antioxidant effect as well. We did not dilate it because there are the evidences are not so foolproof, so we just mentioned. In the cardioprotective side, it prevents sudden arrhythmic death in heart failure patients, particularly in diastolic heart failure and mild to moderate systolic heart failure. Reduces both the blood pressure and pulse rate in morning hours, particularly the early morning surge, and it reduces pulse pressure in elderly patients. So isolated systolic hypertension, it is a drug of choice. So I'll say thank you over here, and I am happy to discuss with you for next few minutes if you have got any queries or if you want to share your clinical experience with me. Over to Dr. Veena, please.
Yes, sir. It was an excellent, very informative talk on the calcium channel blockers, especially highlighting the benefits of cilnidipine in many aspects like new onset of atrial fibrillation, then its role in CA attend study. You have highlighted very nicely the two studies on the CA attend studies, role of cilnidipine in reduction of heart rate, diastolic dysfunction, ambulatory blood pressure, and especially so the comparison in terms of amlodipine and other agents in terms of ankle edema. So it was really a very informative. And as usual, sir, there are a couple of questions from our doctors who have attended the session. So I'll just take up few of these questions, sir. I'll just read out to you.
Please.
So this is the question from Dr. S.K. Panda and many others like Dr. Suraj and Dr. Sudhir Kumar. They all want to know efficacy of cilnidipine compared to other CCBs like amlodipine and the very newly launched one, ezellidipine. How it compares? What is your view on that?
True. Look, cilnidipine milligram to milligram is less potent than amlodipine. You will see that cilnidipine usual dose 10 milligram is usually not effective. Most of our cardiologists use 20 milligram. But as it is very safe, particularly it is preferred by the nephrologist. And I have seen nephrologists giving up to 60 milligram a day. So 30 milligram twice a day. So we cannot really go beyond 10 milligram of amlodipine because there is more chance of proteinuria and renal damage. So in this particular situation, particularly hypertension with CKD, cilnidipine we can go up to very high dose. And though they are basically less potent than amlodipine, but they are a very good substitute of amlodipine. And as there is no the ceiling is very high, there's no harm in giving higher dose, which can make the compensation for its lower potency compared to amlodipine. Ezellidipine, as you see, is, I haven't used so much of ezellidipine, and it is relatively new in the market. I think they are equivalent in potency. I'm not very sure about ezellidipine. I'll leave this question to other if somebody wants to answer, or I'll leave it to your own experience. You can always change it because hypertension is not a very quick killer. So you can always experiment and see yourself how your patient is being controlled.
So next question is from Dr. Nimai Charan. You mentioned about the lifestyle modifications. What is the role of pranayam and jogging and other things in CVD, in prevention or in the management of CVD? That's what he wants to ask.
Look, the lifestyle management is actually universal. They are not meant to control one body condition, like say hypertension or like say diabetes. When we advocate a healthy lifestyle, it means a general overall promotion of health. quality of healthy life, and reduction of overall mortality. So these are not hypertension specific. Yoga, pranayam, reduce stress and strain, healthy diet rich in fruit, vegetable, and dairy products, controlled amount of physical exercise, complete avoidance of smoking, and minimal or no uptake of alcohol, reduction of obesity. These are the fundamental lifestyle changes, including low salt diet. They will affect beneficially not only blood pressure, they affect the body weight, they affect lung condition, they affect diabetes, they reduce chance of cancer, and overall quality and quantity of life. Now, there is a paradox here. If you are a fanatic of all these measures, then it can be a boomerang. If you are very fanatic about one particular type of food, say you think I'll just live on fruits, there is enough evidence that if you don't take some amount of carbohydrate daily, chance of mortality is very high. At the same time, if you think I won't take any salt, then there is every chance that you will land up in ICU with hyponatremia. There is enough data from Denmark and UK that a heavy runner or a gymnast have got lower survival. They have got higher mortality, almost like a couch potato who spent his day in sofa set only. They have got similar mortality. So who live best? That person who is doing normal, moderate daily activities, like a little bit of cycling, jogging, gardening, biking, this kind of, and some sports activity, not who are fanatic about exercise. Similarly, like egg, it was said that if you take egg, you will die. It's just the opposite. Egg is so good for your health. Nowadays we say, take egg maybe 3 or 4 a day, for a week. Same with obesity. You know that obesity paradox, that if you are too obese, you die as much as if you are too lean. So there is a middle path of ideal BMI. So if you scan similarly with diabetes, if your HbA1c is below 6.5%, in diabetes too much control, then there is higher mortality as compared to around 7. So all diabetic agencies now say, keep it around 7, don't be overzealous. As I have told, the European Society of Cardiology said even the blood pressure, do not go below 120 systolic, below 70 diastolic. So everywhere you see, there is a advocacy to take the middle path. So even I would say, with your lifestyle change, take the middle path. Where the middle path is not at all good is smoking. That is perhaps the only thing which really harms you. There is no good dose of smoking or tobacco. Alcohol is a bit controversial. Maybe 1 or maximum 2 peg a day is good, but it has been shown quite conclusively that in Indian setup, in Southeast Asian region, our genetics is such that we cannot tolerate alcohol. So any alcohol is bad for Indians. 1 or 2 peg a day may be good for European or Americans. Again, there is a middle path for them for alcohol. We don't have a middle path for alcohol. So I would advise you that do the lifestyle and changes in moderation that will give an overall benefit of your health and longevity. Next.
So one more question. Can
Yeah.
cilnidipine be administered in CKD patients with serum creatinine level varying between 5 to 6 milligram and the blood pressure of around 200 by 100?
Yes, cilnidipine is one of the drugs you must choose over here, and in a very high dose. As I said, I think a standard nephrologist in India will give at least 20 milligram twice daily of cilnidipine in this case, if not 30 milligram twice daily. So that is number one, because it is safe and it may help the renal deterioration. Of course, you need in these patients drugs like maybe prazosin or doxazosin, which are very good in this kind of scenario because you have to reduce the blood pressure. And depending on your pulse rate and heart condition, maybe a little bit of beta blocker. At this range, of course, ACE inhibitor, ARB are not very helpful. Diuretics usually lose their potency in this kind of scenario. So your options are limited, and cilnidipine still remains in the first line in this scenario.
And Dr. Mithilesh Jha, his own experience, his personal experience, he feels cilnidipine is a weak antihypertensive compared to amlodipine. He mostly uses in mild hypertension and patients with a CKD. What's your opinion about this, doctor? He's asking.
Yes, as I said, Dr. Mithilesh, milligram by milligram, it is quite weak compared to amlodipine. Say 10 milligram amlodipine is never compared to 10 milligram cilnidipine. To me, at least 40 milligram of cilnidipine is equivalent to 10 milligram of amlodipine. But as I said, we can go up to 40, 50, 60. So we can overcome this limitation of cilnidipine. And as you know, that higher the dose of amlodipine you go beyond 5 milligram, chances of unacceptable pedal edema is very high. So we have to make some compromise somewhere because the patients won't take it. I mean, hardly any patient of mine can tolerate 10 milligram amlodipine without very significant pedal edema and discomfort. I try to persuade them to continue with 10 milligram amlodipine and to accept the pedal edema, but most of the time they said, no, we cannot accept it anymore. And then I have to change it to cilnidipine or I have to change the group altogether. Because we cannot be obstinate. We have to reduce the pressure. At the same time, we have to see that the patient is taking the medicine, he is compliant to the medicine, because unless there is no purpose is served. So you have to make some compromise over here. I agree with you.
Then
Next,
question with Dr. Kulkarni, effect of benidipine versus cilnidipine, how it scores over?
I don't think there is any head-to-head trial with benidipine. The same thing comes also for ifonidipine as well as azilnidipine. They were all compared either with placebo or with amlodipine or nifedipine in some cases. But of these new four molecules, as I say, there is no head-to-head analysis anywhere. Some are available not in many countries like Europe and America, where the majority trials come from. Some of them are only in Japan, some of them in India. So there is no head-to-head trial. In my personal experience, benidipine is a good antihypertensive, though I am not very sure about its other cardiovascular effect as we just discussed with cilnidipine. I do not know, I accept my ignorance, whether they have got similar kind of data set with what I could show with cilnidipine for atherosclerosis, for renal protection, for pulse rate benefit, for sudden cardiac death, and so on. I'm not sure, but potency wise, I think benidipine comes in between amlodipine and cilnidipine.
Question from Sanjeev Banik. Patients with CVA in the form of cerebral hemorrhage, where the blood pressure is in the tune of around 180 by 100, what would be the appropriate drug to reduce blood pressure in these cases? Hemorrhage, cerebral hemorrhage.
I think we have discussed it. There is absolutely two drastic different setup. One is the acute setup, first 48 hours, where we are not supposed to reduce the blood pressure. We have to keep the mean arterial blood pressure around 130. So that means 200 by 110, perhaps we have to accept, unless the patient has got acute congestive cardiac failure, hypertensive heart failure, and so on. So first 48 hours, we have to be very gentle with the blood pressure reduction, and we accept the high blood pressure, particularly in stroke patient, as also in hemorrhage patients, because there is chance of further ischemia. Only in subarachnoid hemorrhage, that is a condition where we have to reduce the blood pressure drastically. And to keep the patient, as you know, the drug of choice is nimodipine. We have to keep the patient in absolutely dark place with sedation so that the pressure comes down, the adrenergic drive comes down, and so on. But in intracerebral hemorrhage, up to 48 hours, we are very conservative. After that, whatever be the type of blood pressure, whatever be the type of intracranial hemorrhage, we have to try to attain the optimum blood pressure, that is 140 by 90, and ultimately 130 by 80. gradually over some weeks. There is no rush to do that. And as I showed, that calcium channel blocker is one of the drug of the first line drug, even if in the value trial, long time ago, which compared amlodipine with valsartan, though the overall outcome were similar in both arms, but stroke was much reduced in the amlodipine arm compared to valsartan arm. So calcium channel blockers have got always an advantage to prevent stroke or in previous stroke patients, as I adequately showed in these slides also in today's presentation. So cilnidipine as a representative of calcium channel blocker will be a first line drug in such situation, but we have to be gentle on its use and to reduce the blood pressure gently unless it is a subarachnoid hemorrhage.
So question from Dr. Mishra. What is the drug of choice, hypertensive drug of choice in younger patients?
Younger patients are classically of two varieties. One is the high adrenergic group of patients, like a 30 years old young executive, very overwrought, always running, ambitious, pulse rate is 100 all the time, he is sweating, flushed. So this you immediately know that patient is on high adrenergic drive. Here the drug of choice is beta blocker. And as I have already explained, that cilnidipine type of calcium blocker, which reduces the adrenergic drive, is a good combination. And you know that ARB ACE inhibitor are indirect antisympathetic drug, so they can also be added. But as you know, we generally don't prefer a beta blocker with a RAS blockade together. So either we can give a RAS blockade with a calcium blocker like cilnidipine, or a beta blocker with a calcium channel blocker like that. Another distinct group of this kind of people are that they are otherwise okay, but they have got secondary hypertension, because young patients, the chance of secondary hypertension is very high. Here we should not jump onto blind treatment. We should look into the cause of the treatment, cause of the hypertension, whether it is obstructive sleep apnea, whether it is renal parenchymal disease, renovascular disease, whether it is hyperaldosteronism or some surreptitious drug use. These are the 5 most important causes of secondary hypertension. So we must look into that and treat accordingly. There we have to wait and investigate the patient fully before starting treatment.
One more question from same Dr. Mishra. It's probably a case, acute coronary syndrome in chronic kidney disease with impaired LV function, where one cannot give the ACE inhibitors. What would be the choice of antihypertensive in such type of patients?
If the ejection fraction is low, below say 40% or 35%, then you cannot use many drugs. You cannot use diltiazem, verapamil. That is a big group of drug you cannot use. You have to be very careful in using alpha-zocin or doxazocin group of drug, alpha blockers group of drug. Here the drug of choice, as you know, are beta blocker as well as ACE inhibitor ARB. But as you said, if ACE inhibitor ARB are precluded by renal status, then you have diuretic in your hand, you have got beta blocker in your hand, and as I said, cilnidipine, amlodipine you may have to use, though they are not very suitable in heart failure patients, though they are not as bad as diltiazem or verapamil, but you may have to use them in certain situations where you cannot control the blood pressure. And in acute coronary syndrome, amlodipine, cilnidipine, they are not contraindicated. Beta blocker, of course, is the drug of choice in acute coronary syndrome as well with heart failure. So beta blocker feature in both. And if possible, a low dose of ACE inhibitor or ARB, keeping a very close eye on potassium, not so much on creatinine, but on potassium, which can be balanced by giving a high dose of diuretic as well, you may have to use. That is my take on this kind of patient.
Dr. Rumin wants to know, sir, what's the incidence of pedal edema and gum hypertrophy with cilnidipine? You mentioned it is very less in comparison with amlodipine, but in your practice, what's the incidence?
Gum hypertrophy is a feature mostly of nifedipine. I haven't seen gum hypertrophy with amlodipine, very rare. Cilnidipine, I haven't seen any. Now, as I said, up to 30% of patients on amlodipine have got some kind of edema. Maybe 10 to 15% have got severe edema, so that to discontinue amlodipine. In case of cilnidipine, I have seen 5 to 10% of patients develop some kind of edema, mild, and less than 5% I had to take off cilnidipine because of pedal edema. So I would say about 1/3 of incidence of amlodipine.
Okay. So Srinivas wants to know, what's the role of CCBs in preeclampsia?
As you know, calcium channel blocker as a group are not very suitable in case of pregnancy. But preeclampsia, you know, the drug of choice is alpha-methyl dopa, the beta blockers. Maybe you have to use nifedipine. I won't advocate cilnidipine over here because firstly, the pregnancy safety is not very clearly depicted. And number two, being a relatively weak antihypertensive, and here we need very serious antihypertensive in a very short span of time. I don't think, and it has got no intravenous preparation. So I think we are thinking of cilnidipine in case of preeclampsia. It's not in my box.
Dr. Krishnan Bihari wants to know, can cilnidipine be used in cerebral aneurysm? Because felodipine, which is used, he says it's very costly. So,
you see, the subarachnoid hemorrhage, as I said, the drug of choice was nicardipine because it was tested. Amlodipine was never specifically tested with subarachnoid hemorrhage. I suppose any kind of calcium channel blocker, dihydropyridine group, are equally effective in cerebrovascular, in subarachnoid hemorrhage. But as I said, sometimes we require intravenous medicine in subarachnoid hemorrhage if the pressure is very high. And of course, cilnidipine has got no intravenous preparation. So we have to maybe settle for something else in the acute setup. And then we have got all the medicines in our hand to try in the chronic phase.
sir, people wants to know in the resistant hypertension. Suppose patients on cilnidipine, maybe the CCB, ARB, beta blockers, and diuretic, which still then if it is not controlled, yeah, probably this resistant hypertension. What would be your take?
You know, resistant hypertension, you know, by definition, you have to have at least 3 medicines. One of them is a diuretic. Yeah. So that is the standard definition of resistant hypertension. First thing is that we have to find out that whether it is a true resistant hypertension or a spurious one. Spurious one means most of the time you'll see that the patient is not taking the medicine. They are falsifying you at the clinic. Sometimes there are home conditions which are very unsuitable. And in my experience, you might check with yours as well, that if you admit the patient in hospital for a couple of days, you will see their pressure is controlled. Even with the same medicines that they were supposed to take at home. Actually, you don't need anything else. Just by admitting them in hospital, the pressure falls and gets controlled. So you know that this is a spurious resistant hypertension. Then some people, in my experience also, I found they take some substance which they don't feel it is necessary to mention to the doctor, like some Ayurvedic medicine, like some kind of pickles, some kind of this and that, which contains very high salt or some Chinese preparation where the blood pressure is kept up. Even some people take steroids very silently. And in some homeopathy medicines, there may be steroids. So you have to be careful on all these things, which can be actually curtailed if the patient is hospitalized. Very important latent cause of resistant hypertension is obstructive sleep apnea. And unless you do a polysomnogram, or unless you admit the patient and the night sister tells you that the patient was snoring like anything at night, this is often missed. And then, of course, you have to find out whether you are missing a secondary cause of hypertension, as I just mentioned, the vascular causes, the renal causes, and the endocrine causes. These are the 3 broad group of causes you have to find out. If everything is okay and the patient is still hypertensive with 3 drugs, you add a 4th drug. And go by any standard guideline of either Europe, America, or India, you will see that after RAS blockade, diuretic, calcium blockade, you have got enough choice. You can add a beta blocker, you can add a alpha blocker, you can add hydralazine, and ultimately there are certain other things like renal artery denervation. That is also, again, with Simplicity 3 trial, it's coming up again, getting popular. So you can send the patient to the specialist center. So these are certain things you can do with resistant hypertension. But having said and done everything, there is a proportion of patient who will still remain in the hypertensive range with all your efforts, and then you have to accept it. You have to accept at some point and tell the patient, this much we can do, I can't help more, just accept this thing. And also try to change the lifestyle as much as possible. Try to control the other risk factors like sugar, dyslipidemia, etc. as much as possible, and hope for the best.
So is it like a pseudo resistance, what we generally say?
Yes. As I said, the first part is pseudo resistance, and there could be some true resistance as well.
Yes, sir. So moxonidine as a drug, have you used in your practice and in the management of hypertension? And what's
I've used a lot moxonidine. It is a good anti-adrenergic drug. It is centrally acting, relatively safe. It does not have some of the side effects of beta blocker, like peripheral vasospasm or bronchospasm. So it is generally safe, but you know, the trials are very limited.
Okay.
They are very limited trials. We do not know its safety in coronary artery disease, its safety in heart failure, and various clinical setups. It is not very widely available as well, but at some point of time I used it and it was good. Actually, it is like, you know, like alpha blocker,
Yeah.
like hydralazine or like prazosin. So they are more popular, and they also have got the elderly patient benefit of benign prostatic hypertrophy. But if they somehow cannot tolerate it, you can give this, but be careful about postural hypotension. That is a distinct possibility with this group of drugs, particularly if you use in elderly people. You can always try it.
And sir, you have already mentioned on left ventricular dysfunction and all, but is cilnidipine can be used? There are, I think their questions are repeated, sir. And the CKD, what's the maximum dose of?
As I
There are
said,
few repeated questions are asking.
So if there is no further new question, we can.
Yeah, I think most of the questions, sir, you have taken up. Other like simple questions like what's the maximum dose, which you have already said.
Yes.
And you have already mentioned about the LV dysfunction and all, that was a question. And then
just to re-emphasize, it is not a drug of choice with heart failure with reduced ejection fraction. But if you have exhausted your options like diuretic, beta blocker, and RAS blockade, then among the calcium channel blockers, you can use cilnidipine perhaps.
okay. I think yes, yes, sir. I think it's done mostly. Cilnidipine in prevention. One more benefits of cilnidipine in prevention of progression of atherosclerosis. Does it helpful in cerebral circulation?
Of course, that's what is the
progression of atherosclerosis.
Of that Japanese trial, that there was early evidence that carotid intima media thickness regression is there. So if they can take it in a bigger way, the problem, you know, with this molecule is that as it is not available in Europe and America, we are bereft of big, large-scale trials. Japan, whatever trial is coming from Japan, and in India, mostly we do that, the market survey and the registry data. But good, hardcore academic clinical trials are not so much available with this drug. And I can't see that anything is in the pipeline also. So we have to treat on the basis of whatever data is available and gather our own experience.
So you very nicely you mentioned about that Japanese data and all. It's like a pharmacogenetics what we see. Probably the Indians, do they require higher dose of drug than in comparison with the Japanese population?
Yes, yes, that is always there, because in Japan many of the drugs have got different dosing, including your statins, including other medicines. So they actually require smaller, because of their liver enzyme or something, they require smaller doses of most medicines. We Indians require somewhat more perhaps, but as you see, one good thing about antihypertensive medicine is that you can yourself judge what the drug is doing in what dose. It is not something obscure. It is not something that we are preventing a mortality which you cannot see, which you cannot judge in your clinic. You give some amount of cilnidipine, you see what was the blood pressure, what is the blood pressure now, whether you require further adjustment of dose. So you have got all the time and liberty to adjust the dosing of the medicine. That is the advantage of treating hypertension. You can yourself generate your data and your confidence about one molecule, and you are the best judge to see which molecule in which dose is suitable for your group of patients. Even in India, there are different types of people. They are not same genetically. There is difference between the northeast European, northeast Indian people, with northwest Indian people, South India people. There are all different kinds of people, different kinds of races. So again, there is, like Europe, there's a huge variability from country to country. There are racial difference. So you have to get your own confidence about a particular molecule, which is easy for hypertension management, which is not so easy for certain other conditions where the effect is in subtle things like cerebrovascular accident or CV mortality or total mortality. There you cannot really judge in your own clinical practice. Here you can judge in your practice whether the drug is effective or not.
Sir, I think this is going to be the last question. Nephrologists, they often find it very difficult to manage the blood pressure because of the kidney origin, the hypertension, the renal hypertension. So they generally prefer the nifedipine. So is it so like cilnidipine, can cilnidipine replace nifedipine, or how does it? What's your take, sir?
As I said, nifedipine long acting or nifedipine CD preparation, they have brought it 30 milligram. They are good. They are not too bad for heart also. And as I said, explain that why don't you change your next nifedipine patient on CKD to cilnidipine 20 milligram BD? Give a 1 week trial and see if the blood pressure is equal or less controlled or more controlled. You don't have to ask anybody because there is no such data. But you can generate your own data and own confidence. There's no harm in doing that. In 7 days, nothing will happen so this way and that way that your patient will die. You can always stop the nifedipine and give a 20 milligram twice daily cilnidipine and see what is happening. It's up to you. You're free to do that. Nobody will tell you anything.
So wonderful. I think we are done with question answer session. You really gave a practical tip for the management of hypertension. You said that you can create your own database. That's actually a very helpful. So the practitioner can have their own patients database and they can have their own way of practicing hypertension. As you nicely mentioned, it was a very nice interactive session, sir. I think we'll close the session. I'll just call upon Pankaj to give the vote of thanks. Pankaj.
Thank you, ma'am, for giving this opportunity. Myself, Pankaj Patel from Ajanta Pharma. So Ajanta Pharma is one of the top company in the cardiology, and we have been many innovative and combinations also been there. Trisinod and Synod T20 was one of those initiatives. And we have been committed for bringing the many scientific endeavor for our customers as well. And we are very, from the core of heart, very thankful to Dr. Sumitra Ray for his excellent scientific deliberations and his efforts for this program to make successful. We are also thankful to our all delegates who have been here, who have joined us in their tough time and tight schedule. Thank you once again. I am also thankful to field team who have brought this many of delegates and audiences. I'm thankful to HO team and Dr. Veena and his team also for all the back-end supports. thank you once again. Have a great time, and good night from our side.
Thank you, sir. Thank you very much.
Thank you, Dr. Bina, Mr. Pankaj, and all the
Thank you,
delegates.
sir.
Yeah, it was a good learning, sir. Thank you, sir.